I'm going to talk about how we can use or explore breath as a potential tool to explore biomarkers in a potential screening tool for mesothelioma or to diagnose mesothelioma. So I have no disclosures. So as has been talked before, the problem with mesothelioma is that there's a long latency period between the exposure to the asbestos fibers and the diagnosis of disease. Furthermore, as has been mentioned before by the previous speaker, for the diagnosis we need a histopathological tissue and its assessment. So it's really an invasive tool to make the diagnosis. So we thought, are there any biomarkers that could be used in order to make this less invasive? So what we have tried first, and in the past, a lot of blood biomarkers have been investigated. For instance, like mesothelin or the fibrillin 3 or HMGB1 has been explored, but they have not yet proven to be useful as a potential screening tool. So what we thought, maybe, why do you have to look in blood? Well, for instance, we can have a link with breath because, as we mentioned before, the asbestos fibers are inhaled and they induce a lot of things at the mesothelium. So looking at the breath, the composition of breath, normally it is known that most of the breath contains like carbon dioxide, water, some carbon monoxide and nitric oxide. But a lot of breath composition contains volatile organic compounds. So these are really small molecules that are present in the breath in the picomolar concentrations. And these have given rise to the new era of breathomics since a year of 2030 ago. So we thought if we can use these compounds in breath as potential biomarkers for mesothelioma. Because if you look at the pathway of what happens of mesothelioma, you know that the asbestos fibers, they induce mesothelioma through mostly two pathways. So they induce the inflammation, and they have mesothelioma itself, the tumors have an increased cell metabolism. So these release reactive oxygen species and give oxidative stress at the mesothelium. So what happens with this oxidative stress? So they will attack the mesothelial wall, releasing volatile organic compounds due to the lipid peroxidation of the cell membranes at the mesothelium. So these pool of volatile compounds can be exchanged due to the blood-breath exchange, and they can be released in breath. So with an exhalation, we can have the biomarkers in breath correlated with the exposure to asbestos and malignant pleural mesothelioma. Now, before we could start with doing testing, we have a literature search. And what we found was a bit of disappointing for mesothelioma. So we have found 4 studies. The first one used a technique called gas chromatography and mass spectrometry, including only 13 mesothelioma patients, 13 patients with an exposure to asbestos fibers in the past, and 13 healthy controls. They could discriminate mesothelioma from those patients with 85% accuracy, and they have found 2 markers that were responsible for the discrimination. So they found cyclopentane as a marker for the asbestos exposure, but most importantly, cyclohexane was able to discriminate our mesothelioma patients from those with asbestos exposure. So what happened then? There were 2 other studies with about the same amount of patients that were included using an electronic nose. So the problem with electronic noses is that they do not identify any compounds in the breath. So they just look at the whole of the breath as one, and they try to discriminate between people based on the responses of certain senses to all of the breath compounds. And already that was found okay to do it, the discrimination of those patients from controls. And one study used multicapillary column ion mobility spectrometry as a tool, but they only included 25 patients with benign asbestos related diseases, so most of them were asbestosis patients, and 12 healthy controls. So they did not include any mesothelioma patients, and it was found also doing okay in the discrimination of those. So we asked ourselves the question, can we use maybe these multicapillary column ion mobility spectrometry technique for mesothelioma diagnosis, since it hasn't been done in the past before, and giving the promising results of breath analysis. Now, before doing that, we have to look what do we have to do if we want to have a biomarker starting from nothing to a potential biomarker in the clinic. So first you have to discover which biomarkers are the most important one. We need to validate our results. We need to make sure that what we see is related to the pathology we want to investigate. So we need a biological translation by looking, for instance, to in vitro models. Then the technology can be translated. If you find something, you can build specific sensors, for instance, for it. And then you can really use the next steps into the clinical validation and then the implementation of the test in the clinic. So what we have done in the past is doing the first steps in these files until the step 3. So currently we are doing the step 4 and hopefully try to get to step 5. So what we've done is first did a multi-center cross-sectional case control study with all the university hospitals in Belgium, also with the group of Professor Arnaud Cherpreel in France, and also with the group of Amsterdam. And we try to evaluate the role now of breath analysis for mesothelioma using this eye mobility spectrometry technique. Now, why this technique? This technique is somewhat combining the benefits of the gas chromatography technique with electronic nose sensor technology in that way, so that it allows a pseudo-identification of the compounds. And it's really much cheaper than a GCMS analysis. So that was the first thing. Does it work? Can we discriminate our mesothelioma patients from risk patients with this technique, since it hasn't been done before? The second objective was then to identify maybe the compounds that were present in breath. And also, if we use the other technologies, for instance, GCMS or eNose, do we obtain the same results as has been seen before? And could it validate our IMS technique? Now, for IMS sampling or analysis, the patient just has to breathe normally for 3 minutes through the mouthpiece over here, which is connected to a bacteria filter. So after 3 minutes, breath sample has been taken. It takes about 1 minute, and the patient does not have to do a specific effort. So it's not like a lung function. It's just breathing normally, but with that difference, that's in a tube. After the patient has given a sample, we take a background sample as a reference for potential contamination that the patients have done. For instance, the wearing of any perfume or something like that. So the first study was indeed to explore the possibility to use eye mobility spectrometry, and we included 21 healthy patients who were not occupationally exposed to asbestos fibers, 22 patients who had worked at an asbestos factory in the past, so they really have a good documented asbestos exposure in the past, and 23 mesothelioma patients who were treatment naive, so these were included before any therapy has been given. What has been done afterwards is we calculate the alveolar gradient, as has been mentioned before, is to correct for background contamination. So we subtract the concentration of the volatile compounds in the background from the one we have found in the breath. And afterwards we did a lasso regression, because it followed by a leave-one-out cross-validation, because this allows the selection, the automatic selection of important compounds that are responsible for the discrimination between the patients and the controls. So we get a list of the predictive variables of interest, and with that we worked further on and did a ROC analysis in order to see how good both groups were discriminated. So seeing the baseline characteristics here, we see that most of the individuals were okay, but we saw some differences in age, which can be explained by the fact that mesothelioma patients are older than our control patients, and also differences in the smoking status and the pack years, which can be explained by the fact that asbestos workers were mostly blue-collar workers, where there was a known higher prevalence of current smokers. So this explains the difference between our healthy controls and our other groups. Now, looking at the discrimination of those groups, we could see that we could discriminate mesothelioma patients from our healthy controls and the group with asbestos exposure with really accuracy of 76%, but with 87% sensitivity and 91% negative predictive value, which means that it could be used as a potential exclusive screening tool for mesothelioma, as can be also seen here at the orange line. You can use it to discriminate our mesothelioma patients from our at-risk group of asbestos-exposed individuals. So from this study, there were several compounds that were selected by our regression methods. And you have seen that, for instance, the peaks here, they are called peaks because I have mentioned that IMS ensures a pseudo-identification. So we have peaks 135, 30, 50, 54, and 71 as potential markers for asbestos, for mesothelioma development, because they allow the discrimination of our mesothelioma patients from our asbestos-exposed patients or from the combination of both groups. And we have found some other peaks, peaks 8, 13, and 25, that were able to discriminate our healthy controls from our asbestos-exposed group in all of our models. So these are potential markers for asbestos exposure in breath. So from this study, we saw that really using these eye mobility spectrometry techniques improved the discrimination of mesothelioma patients from our controls. So we had a nice ROC curve. Furthermore, we have found that asbestos-exposed persons could be discriminated from the mesothelioma patients. So as mentioned, it has a screening potential to be used as screening. And we have found several peaks important for this detection. Now, the next question was, okay, we have seen it works now in these patients, and the IMS techniques allows a discrimination of mesothelioma from the at-risk group. So what happens if we increase our study population and include also other important at-risk groups or potentially lung cancer patients? So we included now 52 healthy individuals, 59 patients who had worked an occupational asbestos exposure, had a occupational asbestos exposure, 41 patients with benign asbestos-related disease, of which most of them were asbestosis patients and plaque patients, 70 patients who had nothing to do with asbestos, but who had lung cancer or asthma, for instance, so the benign non-asbestos-related diseases, 56 primary lung cancer patients, also treatment naive, and 52 mesothelioma patients who were treatment naive. Again, we did the same thing, the same sampling setup, and here you see also the same differences coming up. Here we see also the smoking status that differs because lung cancer patients were known to be smokers, and the same thing, the blue-collar workers also were known to have a higher prevalence of smoking, which reflects both. Also, we see age differences, again, because of the older population who gets the tumors, and also some gender differences. Now, these are the ROC curves comparing the several groups. So, if we focus first on the discrimination of mesothelioma patients from both our at-risk groups, so a combination of those with an occupational asbestos exposure and those with benign asbestos-related diseases, we see 85% accuracy with a sensitivity of 94% and a negative predictive value of 96%. And again, we see the same compounds coming up again, so peaks 135, 137, 21, 26, as has been seen in the previous study, and the discrimination of both groups, which is also reflected in the ROC curve here in green. Now, if we wanted to, what was interesting is looking at the discrimination of mesothelioma patients from lung cancer patients, we see that it was possible, although the accuracy was lower. And we think that this could be reflected by a more common pathogenesis between the both, so that those could be related to a potential tumor-associated inflammation rather than tumor-specific. Although, since we have obtained a rather modest discrimination, there have to be some compounds that are specific enough to allow this discrimination between both of the groups. Now, those are the curves. For instance, if you want to discriminate lung cancer patients from those with our asbestos-exposed group, based on the same compounds, we also have a nice discrimination of those groups. So if you have an asbestos exposure, it could be used to discriminate it from lung cancer or from mesothelioma. What was interesting to see is that we could not discriminate between our asbestos groups with occupational exposure or with benign related diseases based on also same compounds. So this accuracy of 55% shows that there's no difference between the two, and so that's also why we have pooled those two groups into the comparison group with the mesothelioma group. Now, from this study, we have seen again that mesothelioma patients could be discriminated from those with an asbestos exposure, benign asbestos-related diseases, or with benign lung disease, which has not been focused upon here. But we have found the same compounds as in previous study as the most important ones selected in this discrimination. And furthermore, we have seen this modest discrimination between lung cancer and mesothelioma patients. So there's potential in inflammation-related compounds in breath related to the tumor. But as mentioned, there must be some specific compounds present since we have obtained a discrimination between those groups. Now then we have set up a third study. We want to know which are the compounds because I have always talked about peaks and P1 and P3, etc. So we did another setup, a small study, to look with GCMS, this is the gold standard in breath analysis, and with sensor technology to see does this validate our results we have had in the past, and is it promising for future miniaturization for a potential breath test. So we did a different setup. So the patient has to breathe in a mouthpiece, breathe through a VOC filter over here. So they breathe in through a non-rebreathing valve, and they have to fill up a bag of air, so one full expiratory vital capacity volume into a 10-liter bag after 5 minutes of tidal breathing. And out of this bag, we sample about a half a liter over such Tinax columns, and these columns are then sent out for analysis with GCMS or with eNOS. Now, for this study, we included 64 participants, so 40 mesothelioma patients, 19 with occupational asbestos exposure, 15 with benign asbestos-related diseases, and 16 healthy controls without an occupational asbestos exposure. And for GCMS analysis, we have selected 139 volatile compounds in breath, again followed by a Lasso regression and cross-validation for the analysis. And the electronic nose analysis, so the sensor technology, consisted out of the combination of 4 different sensor platforms, and we did a principal component analysis on the data, followed by a linear discriminant analysis and also a cross-validation in order to obtain our results. Now, looking at those groups, the comparison, again, the same remarks. So there was a difference in age because of the elderly population who had malignancies. So for GCMS analysis, these are the results. So looking at the blue line, this is the mesothelioma versus the group of both asbestos-exposed person population. We see a very good discrimination. This is the green line. And the discrimination has 100% sensitivity and negative predictive value and 94% accuracy. What was intriguing to see is that there were 7 compounds selected, but one of those, again, the cyclohexane pops up, which was also found in the previous study that has been done before. Again, what did we see before is that we could not discriminate between both groups with occupational asbestos exposure, but with or without benign disease. So this also validates our previous finding with IMS. We could not discriminate between both of the groups, which is reflected here into the purple line. Now, results for eNOS have a lower characteristics, but again, we have inline results, so we could discriminate our mesothelioma patients from both control groups, at-risk control groups, and again, no difference between both groups with and without asbestos-related diseases was possible. So the thing is to conclude from this study, so we have a good discriminating capacity of our mesothelioma patients from the at-risk groups, so again underlining its potential given the large sensitivity and negative predictive value. With our electronic nose analysis, we found inline results, and furthermore, we have found some key volatile compounds that allowed this discrimination and could be potential new biomarkers for mesothelioma, including the cyclohexane that was found in the past. So what we have done now in the previous mesobreath studies was do the discovery phase. So with the IMS, we have found some important compounds. We did a sort of validation by including more patients and more control groups. So we saw the same compounds popping up. We did technical translation over here with a GCMS and electronic nose. We have seen that there are different compounds identified, including the cyclohexane, and it has promising for future miniaturization. But also, the next step to do is the biological translation. So what we measure, does it relate to our mesothelioma, or is it something that's just inflammation associated with the tumor? So therefore, we have started up a Mesobred-4 study that tries to explore cell lines and pleural effusions for VOX in the headspace of those cultures. So before we started it, we looked in literature what was already present or known about volatile organic compounds and headspace analysis in those lung cancer and mesothelioma cell lines. And really, that's all that came up to today. So we have found some studies, and there were differences concerning the samples that were used, the methods that were used, and the compounds that were identified. So in short, the most studied population were lung cancer cell lines. Most studies used the adenocarcinoma cell line, the A549, and only one study included a mesothelioma cell line, so the REN. So there really was a gap in doing some headspace analysis with these mesothelioma cell lines. There were some studies doing other sample types, for instance, pleural effusions, or used lung tissue to attract these compounds. And as controls, most used non-cancerous cell lines, so just control cell lines, or just a medium control to compare the results with. So as mentioned, or previously mentioned, gas chromatography and mass spectrometry is the most frequently used one, because this allows the identification and quantification of the compounds in breath, which is really necessary, but it's really, really costly to do so. Others try to differentiate using other techniques, of which the electronic nose also was a lot used, and this is the one only used on the mesothelioma cell lines. So out of the cell line that was used, we could not get any compounds because they used sensor technology. So we don't know what discriminated this group from our other groups. For offline sampling, most also use these absorption tubes, which we have also used in the past, but also some fiber could be used to attach some compounds, or bags could be filled by using up the air that's above the headspace. Online sampling are also other possibilities. For instance, the IMS technique that we have used in the past, and we are currently also using on our study. So knowing that. One more. Those are the compounds that were detected in the headspace of these lung cancer cell lines, because mesothelioma was done with the electronic nose, and those are all the compounds that were present in 2 or more of the different literature articles. So not really anything popping up or accompanying the things we found. So no cyclohexane was in this studies. So for lung cancer, also we can see that no compounds can be used as a standalone biomarker, just to the small number of studies and very large inter-study differences in techniques used, statistical analysis that has been used, or the methods. So we wanted to know, really, are compounds now derived from the mesothelioma itself, or it's specific for mesothelioma, or what we have seen in breath, is it now inflammation that is associated with it? So what we have done is a pilot study, including 3 different cell lines. So we have a sarcomatoid cell line, an epithelioid mesothelioma cell line, and we included a lung cancer cell line also in a second study. And we compared using culture flasks, and we will see here. So we have a blank control, medium control, and then medium control with our cells. Each one is combined to one Tenax column. We subtract the headspace air above of it, and we send it out for central analysis with GCMS. Now, as a result, you can see that it was able to discriminate or to differentiate our blanks, so the red circle over here, from our medium, the green, and also the 2 cell line types. So we have a differentiation of epithelioid from sarcomatoid. It's not that clear, but we have one outlier over here that causes this overlap between those groups, although they are really nicely centered for the rest. So it has some potential in discriminating those groups. Looking at then the heat map on the right, we could discriminate again, so the medium, which is the purple, from the blank, which is the black. And those are really separated from the cell types. So the cell types were discriminated from our controls. And looking between the cell types, we could also find some discrimination with low overlap between those two, based upon those compounds mentioned on the right. Now, what happens if you include a lung cancer cell line into this model? Again, you see the medium, which is now the black, is totally separated from our cells. We can see the epithelioid mesothelioma cell also separated from the others. But what is interesting to see is that we could not have a nice discrimination between our sarcomatoid and our lung cancer group and our lung cancer cells. So this also reflects what we have seen in breadth, that lung cancer cells are not specifically easy to differentiate from our mesothelioma cells. But we have some differentiation with our epithelioid mesothelioma cells. So this underlines what we have seen in the in vivo situation. Now, looking at all of the studies that has been done now previously and what we have done in the last 3 studies, is basically we have inline results, certainly looking at the accuracy, and given the promising sensitivity and negative predictive value, a breath test could potentially be used as an exclusive screening tool, where patients with an asbestos exposure or known asbestos exposure could undergo this breath test, and the negative breath test could not subject them to further follow-up with the current invasive methods. And again, we have found cyclohexane as a potential marker for mesothelioma. Again, we have seen in the first 2 studies a modest discrimination between mesothelioma and lung cancer patients, but given the fact that we did get some discrimination between both, there must be something that's tumor-specific. We have also seen that in the in vitro situation, and we have found some interesting compounds with this ion mobility spectrometry technique. With our GCMS, so the gold standard, we have identified compounds. Indeed, cyclohexane also came up again. And also the sensor technology is promising for future miniaturization based upon the compounds we have now identified in the previous study. And the in vitro analysis, which is currently going on, also allowed to discriminate the medium from the blanks, from the cell lines, and also the modest discrimination of the lung cancer from mesothelioma reflects the in vivo situation. So what we are currently trying to do is first correlate these compounds with the pathogenesis of mesothelioma. So again, extending our in vitro research, looking for new biomarkers, including more mesothelioma cell line cultures and pleural effusions. And we are doing, which has been started since a month or 3 ago, is the external validation of our breath test. So we are now including an independent cohort of mesothelioma patients and asbestos-exposed persons to validate our test, to see how good the test predicts who will get mesothelioma or not. Also do a prospective follow-up study, so we are planning to do that in the future, to compare the breath test with a CT scan in asbestos-exposed persons to see whether or not it could have a place in the diagnostic workup for mesothelioma, and miniaturize our data by building specific sensors only sensitive enough for the compounds of interest and not for the whole of the breath, which will include the sensitivity of the test. So with that, I'd like to thank all of the collaborators to the studies and you for the attention. Thank you.